I am Sam Reynolds. Really appreciate the introduction. I first started taking care of patients with Erdheim-Chester disease when I was in fellowship at the University of Michigan. This is actually about 4 or 5 years ago now, and Dr. Azra Ahmed and myself had quite a huge group of patients, not only with ECD, but related to histiocytic neoplasms, including Rosai-Dorfman disease, Langerhans cell histiocytosis, and other disorders. At the time, I was only kind of distantly acquainted with the ECDGA, but it's since become a major part of a career that I'm very proud of and still building with my colleagues around the country, including folks at UAB, where we're going to have our meeting this year, I believe, Mayo, Dana-Farber, and of course, internationally as well. What you're going to see in the subsequent slides is actually quite image and graphic heavy. I try to do as many figures and pictures as I can. On a personal level, I think whenever I'm explaining a complex disease state to patients or dissecting the complexities of a rare disease specifically, I find it most helpful to not put too much text on the slides and to kind of keep it brief. And I've tried to leave plenty of time so I'll be able to pause throughout and answer questions, and we can also do questions at the end. And finally, I think many of you may have heard this. I am dog sitting my two beautiful dogs at home today, so there might be the occasional dog barking. It just means that they're very excited about the exciting molecular landscape of Erdheim-Chester disease. So, without further ado, why don't I kind of jump in? This will be review, I think, for most of you, whether you're patients or providers. A lot of this might feel very familiar, but please stop me throughout, however often you'd like. Today, I'm going to speak a little bit about what ECD is, its clinical heterogeneity, why that's complicated, and how we guide decision making. And then on a deeper level, what makes it unique in terms of the mutations within cells, how patients might respond to therapy, sort of our classical treatment approach, and then where we're at with advances in therapy. I've actually taken the liberty of including what I think is some kind of late and breaking research and new research directions in combination with my leukemia work and something Dr. Ebikun is doing over in Mayo. So I hope I can show you or at least give you a glimpse of the latest and greatest that we're sort of hoping to get out there in the next year or two. The first thing I'm going to do is show you I'm not much of an artist. So I'm going to show you a terrible rendering of my understanding of the origin, not only of Erdheim-Chester disease, but truly the origin of all hematologic disease, whether it's leukemia, lymphoma, by starting with a picture of a bone. So again, this is my terrible drawing in PowerPoint of a bone. If you were to slice open the bone marrow of any patient, a patient with or without Erdheim-Chester disease, any condition, you'd find these power generators stored within bone marrow. They're better known as hematopoietic stem progenitor cells. Of course, on a colloquial sense, we know them as stem cells. So the origin of every drop of blood in the body all starts with the HSPZs or stem cells. They have hundreds of thousands of functions. They're influenced by many intrinsic marrow factors as well as various environmental stressors. But for the sake of this presentation and for the sake of simplicity, I like to think of the bone marrow as having three primary functions. So what you're seeing is kind of the product of bone marrow turnover and metabolism. The first function of the bone marrow and stem cells we all know quite well. So red blood cells are an essential product that come out of the marrow. They're really important in terms of oxygen binding using a protein called hemoglobin, later oxygen transport and ultimately delivery. The bone marrow also produces platelets, which have an impact on a process that we call primary hemostasis. We know this more in a general sense as a blood clot formation. So real simple to start, red blood cells carry oxygen, platelets stop bleeding. But there's another population of cells that's generated in the bone marrow called white blood cells. Now, these are much more diverse and is truly the reason we're all here today on this meeting. Try to think of white blood cells in the same way that you might think of a chessboard. You have kind of a front line of defenders, and then you have this second line of cells, which have different functions depending on the patient. But in a very broad sense, every white blood cell on the bottom left here begins as an undifferentiated stem cell. That's why it's called a stem cell. It's the very beginning of cell development. Some of those stem cells will then become lymphoid cells. So you may have heard of T and B cells. So there's an entire lineage or line of cells that either become T or B cells. There's also a set of cells that we know as myeloid cells. Okay, so these are, a myeloid lineage or anything can come from a myeloid cell, but specifically, these will later produce what we already reviewed, which is red blood cells and platelets. But more importantly, myeloid cells give rise to granulocytes. There's several different types of granulocytes. There's neutrophils, eosinophils, basophils. If you're ever interested in knowing what your granulocyte makeup is, take a look at the differential on a CBC next time you're at the PCP's office. I guarantee you, everyone in this call, including patients, physicians, providers, we've all had a CBC before. So this is actually the information that differential is capturing. So granulocytes are produced from the myeloid lineage. And then we talk about this cell type called monocytes, which I'd like to spend a little time on briefly. But in general, I do things a little bit differently than most oncologists. I don't just like to tell patients the diagnosis and say, here, here, here. I think you should really have a good understanding of the origin of all disease. Because to be frank with you, every blood cancer that we know, whether it's leukemia, lymphoma, or a histiocytic neoplasm, including Erdheim-Chester, is all generated or captured somewhere within this process. So you probably noticed that I made monocytes the biggest cell on the slide. Let's dig a little deeper into monocytes. So monocytes, I mean, in Latin, like it just means a single cell or a single center of a cell. There's a lot of diverse functions of monocytes, right? And when the babies are developing in the embryonic stage, yolk sacs or fetal liver monocytes will later become what we know as bone cells or bone building cells and osteoblasts. They'll also become microglial cells that'll then later differentiate into astrocytes. So monocytes can become many different things. So bone, CNS, okay? If you look all the way on the right, monocytes can also circulate all over the blood, and they make up a lot of what we know is the character of the spleen. So the spleen's a very essential organ for the processing of debris in different inflammatory products, right? But in general, monocytes have those two functions. They arise very early in the development of a baby, and they're also present in adults and circulate and respond to problems. Then there's these monocytes that settle into the body. Okay, so picture a white blood cell that leaves the bone marrow and just kind of goes to its police station. Okay, it goes to the liver, the lungs, the brain, the legs. Anywhere in the body, there might be a problem, and there might, we might need a police officer, we'll say, to kind of look for a problem or a garbage man that can clean up garbage. You will see a monocyte. These are later known as tissue-resident monocytes or histiocytes. Okay, so we'll go back one slide. Monocytes come from the bone marrow. Monocytes later settle into tissues and are known as histiocytes. What happens if something goes wrong? If one of those specialized white blood cells acquires a mutation, it's no longer a histiocyte. It's a histiocytic cancer or neoplasm. Broadly speaking, these are separated into one of two camps. There are Langerhans cell histiocytic neoplasms. These were simply named by the person who discovered them. These express certain markers that we won't discuss today. And then the reason we're here is non-Langerhans cell histiocytic disorders. There's two different types, and quite frankly, is the majority of my research right now is focused on Erdheim, but I think it's very important to acknowledge that one very common type of non-Langerhans cell histiocytic disorder is called Rosai-Dorfman disease. They're similar in their antigenic or protein expression on the surface, but they're vastly different in how they present. But just please be aware, a Erdheim-Chester disease is a non-Langerhans cell histiocytic disorders. When we're in clinic with patients who have never heard this before, the way we describe it is it's kind of a cancer of specialized white blood cells called histiocytes. I definitely don't need to explain to anyone on this call or anyone in the ECDGA more broadly, how diverse Erdheim-Chester disease is. It's not a one size fit all. So I want to spend the next few minutes talking a little about clinical heterogeneity or the diversity we see in patients who present with Erdheim-Chester disease. We all know on the left, I've already covered, it's a non-Langerhans cell histiocytic neoplasm. This all comes from, histiocytes, which reside in tissues. But because normal histiocytes are there to process or in some cases comprise scar tissue or break down the product of different inflammatory processes, a lot of what Erdheim-Chester disease manifests as clinically is sclerotic lesions or fibrosis in end organs. We can kind of go head to toe. Patients can absolutely and often do present with central nervous system disease if Erdheim-Chester disease or neoplastic histiocytes involve the brain, the pituitary gland, or even the eyes. This can cause protrusion of the eyes. If it involves a structure stemming down from the brain called the pituitary gland, patients have all sort of endocrinopathic sequelae, such as excessive thirst, urination, sometimes even male breast enlargement or gigantism. Patients who have disease, Erdheim-Chester disease involving the center of the chest, can develop fibrosis and scarring around the center of their heart. Very frequently, patients will present with kidney injury or kidney failure because of fibrosis or sclerosis around the kidneys. And certainly, we know a hallmark feature in many patients is lower extremity pain or discomfort due to excessive sclerosis of the joint, kind of interfacing between the tibia and the knee. So, head to toe, I think it's a very unique disease, and I'm going to show you some more specific pictures shortly in that it's not one size fit all. What one person's Erdheim-Chester disease might be completely different than another. I have a patient I'm seeing in 2 days with ECD, and he came to me because he felt like he had pneumonia for about 2 months. And his oncologist, about an hour away from me, called me, and he came to clinic, and his heart rate was in the 140s. He couldn't breathe, and it turned out he had Erdheim-Chester disease all over his lymph nodes, and ended up getting on vemurafenib. Has since kind of stabilized, is doing quite well. But he was certainly unique to me in that everyone thought he had pneumonia, even lymphoma at one point, and it ended up being something different. So the group of people I'm talking to right now, and the group of the global community that we all serve, is not just one type of patient. It's not just one type of person. It's a very clinically heterogeneous disease, and I just want you to kind of remember that. What does it look like? A literature search anywhere, um, whether it's through Google or PubMed, or another database, will show you pictures like this. Don't want to go through everything in extreme detail, otherwise it'll feel like a tumor board, but just be aware that this is a cross-sectional picture of a heart on the top left here. These are different chambers of the heart, and this is actually a patient who had a mass or sclerosis in the atrium of the heart. So the entry point of the heart actually had scar tissue in it, and this patient was in florid heart failure. Other patients who have Erdheim-Chester disease who undergo bone scanning, they have this really significant enhancement in the tibia or lower legs bilaterally on both sides. And then there are many patients who present with disease in the cerebellum. This is a cross-sectional image of the base of the brain. And then to give you a little bit more of a graphical depiction of what this looks like in the kidneys, this is actually the kidney in red on the top right here, and everything around it is sclerosing and fatty infiltration. And on imaging, what they'll call this is a hairy kidney. It's two kidneys that are diffusely inflamed. The images and pictures and presentation goes on and on. These are just various cross-sectional images, as well as magnetic resonance images showing disease in the pituitary gland, in the brain stem, more patients with problems directly in the cerebellum as well. The kidney enhancement on the top right, and then don't forget there are cutaneous manifestations. Periorbital xanthelasmas is a rather striking feature of another related disease called juvenile xanthogranuloma, but we also see it in Erdheim-Chester, where patients have these kind of fatty or cholesterol heavy deposits around the eyes. Not an atypical presentation in any sense. So Erdheim-Chester disease, I think, driving home the point that it looks different in every patient we see it. Um, digging a little deeper into why this is, because I think whenever we're learning these concepts in medical school or in residency or even fellowship, it's still kind of an emerging disease state, right? A lot of, I think, doctors, patients, providers around the world, we're all left kind of scratching our heads whenever we approach Erdheim-Chester disease in the sense of identifying a unifying diagnostic criteria and really coming to an agreement as to what is the clonal architecture of Erdheim-Chester disease relative to other problems. So I'll tell you that broadly speaking, Erdheim-Chester disease, Langerhans cell histiocytosis, and Rosai-Dorfman disease all share some commonalities from the standpoint of their genetic makeup. When I'm talking about genetic makeup, I'm not talking about a mutation that you inherit from a family member. I'm talking about something called a somatic mutation, meaning a mutation that you develop after birth. Most commonly, patients with Erdheim-Chester disease, LCH and RDD, will have an alteration in the MAP kinase pathway. Without getting too detailed about what that means, patients will either have a mutation in BRAF, KRAS, MAP2K1, or another one of the RAS variants. These are all proteins that affect growth of cells. So if you have a mutation in a protein that affects cellular growth, or in a gene that codes for a protein that affects cellular growth, rather, you're going to see a lot of overgrowth of scar tissue, a lot of overgrowth of cells. These are commonalities amongst all cancers. But just be aware that somatic mutational burden in histiocytic neoplasms is rather diverse, but certainly BRAF is the most well-established mutation. Getting even deeper into what this looks like, the actual pathway, the MAP kinase cascade, is depicted in green in the center here, depicting the progression of the activation of RAS to RAF to MEK to ERK. Anyone who's been in a cell biology class or a college biochem class will tell you that these pathways are very often emphasized. But without getting too technical, I'll just tell you that the outer part of the image here in orange is a cell membrane. So it's the first thing anything in your body sees once it interacts with a cell. There's signal that's transmitted through this receptor here. It kind of looks like an open pair of hands. And then you have activation of all these genes. Normally, there's what's called negative feedback. So once all these proteins have been activated and have influenced something involving DNA activation or something involving transcription, there's usually something called negative feedback, okay, where this process kind of knows how to shut itself off. But if you have a mutation in the DNA where one of these proteins is being overproduced, it's going to be highly problematic, and you're going to see overproduction of many cells. Again, universally in cancer, this is certainly a problem. On the right here is a rather exhaustive list of many different authors, some of which we know in our ECG community very well, who have established what we know as the genetic landscape of Erdheim-Chester disease. And most of the mutations that we see listed or depicted here on the right are very well established to be, characteristic of this disease state. So this is something we know to be very true. In the last 5 years, it's been very exciting. We've known that BRAF mutations for a very long time are are perhaps the most dominant mutation. Just like many of you, I'm sure, have heard that the BRCA mutation is the most dominant mutation in breast cancer. But what I think has been more exciting is that you're seeing this shift towards more comprehensive genomic profiling in Erdheim-Chester disease. Okay, in non-medical terminology, we're becoming more and more aware that it's not just that patients look different, or that people look different with ECD. Their genetic makeup is different too. So with that, I'm going to show you a snippet of the National Comprehensive Cancer Network guidelines. Again, I do things differently than most oncologists. I think that every single patient should have a window and see exactly what we see when we're making treatment decisions. There might even be some people on this call here who are on some of these medications, but in Erdheim-Chester disease, if you have end organ disease or severe disease requiring treatment, and you have a BRAF mutation, or you have a certain mutation that we identify in your tissue, we'll usually try to put you on a BRAF inhibitor. If you have a mutation, in vemurafenib is a very classically utilized drug. If you have a mutation in the same pathway, but it's not directly BRAF mutated, remember back to this picture. Okay, if it's not RAF, but it's something else, we can still use other medications like cobimetinib, dabrafenib, trametinib, all these drugs that target the central part of that pathway. But the reason I'm here to talk to you today isn't because of those drugs. We know it's very, very well established that those are the most dominant clones in these disease states. What I'm excited about in our field and in the direction I certainly hope we move in is all of these letters and numbers on the right side of the screen. ALK, CSF1R, NTRK, RET, PIK3CA, PIK3CA. These are all mutations I've certainly heard of in other disease states, but until recently, we didn't know in a global sense how prevalent they were in in Erdheim-Chester disease. The reason this is important is because we're entering an era of precision oncology. In Erdheim-Chester disease, patients are no longer, solely going to undergo BRAF specific, allele-specific sequencing. Patients are going to have more comprehensive NGS panels performed on their tissue, on peripheral blood, bone marrow, whatever we're obtaining a biopsy of, and we'll be looking for ALK fusions, CSF1R mutations, NTRK gene fusions. All the drugs then listed to the left can then be paired or tailored, if you will, to whatever mutation or fusion that you have present. There's always chemotherapy, there's always anti-inflammatories, but I certainly hope that in patients with these mutations that we're entering an era where we can utilize these drugs for the specific mutation. I'll pause there because I saw a raised hand. I don't know if I can see the chat window, so Q&A, here we go. Okay, and I'll start with the first one. Is it known why the histiocytes go to different organs and tissues for different patients? Can it be predicted what organs might be affected based on mutation? Excellent question. There is some theories in cell migration models that depending on where, I'm actually going to show a slide later that I hope will help answer that. Depending on where in the process of a monocyte's differentiation in development, can dictate where it goes. So I'll give you an example. If a patient acquires a mutation in a monocyte when it's still in the bone marrow, it can pretty much go anywhere, right? Because the bone marrow will then spit out monocytes with mutations that can settle in any tissue. If the monocyte gets to a tissue and then patients acquire a mutation later in the course of their adult life, it usually affects that specific tissue. The second question, can it be predicted what organs might be affected based on which mutation? To some extent, yeah. Patients with CNS disease, central nervous system disease, tend to harbor more BRAF mutations or MAP kinase alterations. I've personally seen less of that in patients with other fusions. So, to answer your question, from Anonymous, yes, it can be predicted, but not with perfect certainty. We're kind of working that out. There's certain labs that are working that out right now. Mark, I saw a question here too. How many times do you see a secondary bone marrow issue? You were recently diagnosed with AML. Two chemos have been successful in lowering chemo. I'm really, really happy that you brought this up because I'm actually at Moffitt. I'm an AML specialist. So in about 5 slides, I'm gonna show you a working theory that I have that I hope will help answering that exact question. So far, so good.
Sounds good.
All right. I love the question about AML. And Mr. Kelps, I'm very sorry to hear that, but I do treat AML every single day, and this is a research question I have right now, and to be frank with you, part of what I'm hoping to get some funding for is to better understand that. So let's move forward to what are we missing here? It was actually what the question that just came up is a perfect segue into the last part of my talk. Clonal evolution and working at the core of the disease. What I just showed you in the past 10 slides is what we see when Erdheim-Chester disease has manifested in the body, okay, or different parts of the body when patients are in organ failure, when you're already requiring systemic therapy. But how does this disease evolve over time? How does it change over time? I thought the two questions were excellent. The questions were, okay, can we predict what organs are going to be infiltrated by mutations, and is there any association with other malignancies? So let's dig a little deeper. A little shameless self-promotion here. This is a paper I published about a year and a half ago with a resident that I was working with at the University of Michigan, and one question I had, well, what's happening in the bone marrow? What's happening with these monocytes? It's one thing to look at this disease on MRIs and look at all these pituitary lesions, but what's happening at the very earliest part of the disease? So one thing I asked him to look at, based after seeing Dr. Durham, Benjamin Durham present at a conference, I'm like, okay, well, he talked a lot about shifts in monocyte subsets in the bone marrow of patients. What can we garner from the peripheral blood of patients who undergo treatment? And one thing that we did find, and I didn't include p-values on the right, but this was a significant drop. We found that monocytes declined significantly in patients who had pre who had progressed on therapy and then undergone treatment. So anyone who, say, failed an initial line of therapy but was reinitiated on therapy, the monocytes dropped very quickly. Even if the second line therapy was radiation or surgery, the monocytes dropped. So I thought that was a very interesting observation. It certainly would fit with the disease, right? We know that the disease comes from these monocytes in the bone marrow, but the fact that they're dropping with treatment tells us that, whatever we're doing in some sense is working on the disease, but the question still remains why? Why is all this happening? So I thought back to my earlier picture and I thought, what's happening in these monocytes? What's happening at the core of the disease? This is where I want to pivot here, and I hope I'm getting this name right. Is it Mark Killips or the individual who asked that question? I thought very appropriately asked, is there any association with other diseases or AML? Well, one thing we're looking into right now, this is a very active question in the field, is another diagnosis called clonal hematopoiesis. Okay. Clonal hematopoiesis is actually when those stem cells, the cells in the bone marrow, acquire a mutation at some point in the course of their development or some point in the course of adult life. We know that clonal hematopoiesis can either exist by itself, meaning you just see a mutation and there's no problem, or it can exist in association with other conditions. It can even lower your blood count, in which case clonal hematopoiesis becomes CCUS. And that the mutations that we use to characterize clonal hematopoiesis or stem cell mutations can change and evolve over time. I'll skip through this because this is a risk model that was published by Moffitt pertaining to MDS, but just be aware that the clonal hematopoiesis, CHIP, and CCUS, other bone marrow conditions can eventually evolve into AML, and different mutations at the level of the bone marrow can predict for development to AML at a later time in life. One question that still hasn't been answered, and I hope this will help answer one of the questions that got brought up in the Q&A, is how does this connect with Erdheim-Chester disease? There has to be some association, right? If patients have clonal hematopoiesis with Erdheim-Chester disease, or there's an association, why can they not be related? Why wouldn't they be? Think about it. You have an early stem cell that later becomes a monocyte. That monocyte will later leave the bone marrow, settle into a tissue, and then you have Erdheim-Chester disease. Does that happen once the monocyte leaves the bone marrow? Does the monocyte pick up a mutation when it's in the bone marrow? Good question. Papo and Durham have explored this and are actively still exploring this in their labs. Patients who acquire a mutation in the bone marrow, okay, when the stem cell differentiates, okay, it's already a mutated stem cell. You already have something called clonal hematopoiesis. When that stem cell differentiates into a monocyte and a new mutation is acquired, now you've got two problems in a sense. You have a stem cell that has become a monocyte that now harbors two mutations. So you have a bone marrow problem called clonal hematopoiesis, and now you have a stem cell, a monocyte that goes to the tissues and becomes Erdheim-Chester disease. The question that was posed earlier is, I've recently been diagnosed with AML. Is there any association between AML or any data for how these diseases evolve in tandem? The answer is yes. What I believe is happening here, and I think what our community is still trying to explore, what I hope to explore in my research in the next few years, is that this is all happening in some degree in the bone marrow. What we see on the MRIs, in the CT scans, and I'm just going to disclose this because I know I'm being recorded. I cannot prove this 100%. No one has yet proven this. These are all still working theories, and I've cited all of these studies in my presentation, but I do want to give you a sense for what we're trying to think of or what we look forward to in the field. which is that at some point during the course of a stem cell's development and differentiation, you have a single mutation and then you later acquire a different mutation as that stem cell becomes a monocyte. And then when the monocytes leave the bone marrow, in rare cases, these are rare diseases, they later become a mature histiocytic neoplasm. So it's very feasible that a patient could develop Erdheim-Chester disease, and all the while the Erdheim's getting worse, patients can have evolution or change in their bone marrow to where they also develop AML at the same time. So yes, I have seen that, and yes, it's possible. So some of our unanswered questions, I think, in our field are, and I won't bore you with this too much, but one of the research questions I'm very excited about asking is whether or not histiocytes in stem cells, in the changes in the mutational character we see, from the within these stem cells evolve over time in tandem with Erdheim-Chester disease. Speaking in non-medical terms, I'm really interested in how the bone marrow changes over time as Erdheim-Chester disease changes. Do we see mutations in the bone marrow progress or develop as we see changes in Erdheim-Chester disease? What if you failed treatment for Erdheim-Chester disease? Well, why did that happen? Did you develop a new mutation to where your pill stopped working? What if you got chemo and all of a sudden you have a new problem? Okay, do we need to tailor the medication in Erdheim-Chester disease to better suit what is going to be your new disease character? These are all very complicated research questions. I don't have all the answers. I don't think anyone does yet, but these are the questions we're trying to answer. And one of the reasons I'm so passionate about collaborating with the ECDGA. With that.